Hello everyone, I'm Dr. Conrad Fisher, and I'm here to help you prepare for your test, to make sure that you are fully confident on test day so that you'll be able to relax and show all of your knowledge to your best abilities. This section of cardiology, the acute coronary syndrome, is a very good example of how we're going to analyze diseases for maximum question extraction. You'll be given a history and physical, maybe some labs, maybe not some labs, and be asked the basic questions. What is the most likely diagnosis? And how will you distinguish it from the others? What is the best initial test? What is the most accurate test? What's the best initial therapy? What are the complications of those therapies? Which of the following is the most likely physical finding to be found in this patient? A person comes in with crushing substernal chest pain. What is the most likely diagnosis? Well, infarction, yes, but you can't really tell if it's an infarction or just ischemia till you get an EKG and enzymes. What is the best initial test? Is an EKG. What is the most accurate test? And the answer is CKMBs and troponins. What's the best initial therapy? Now, what's the difference between a person who gets a low score and a high score? The person who gets the highest score is able to handle questions where it says aspirin has been given. What is the next best step? Aspirin and clopidogrel have been given. What is the next best step in the management of this patient? Aspirin and clopidogrel and low molecular weight heparin have been given. What is the next best step in the management of this patient? That is the key issue between a clinical examination like this and the basic science exam, is the order in which to do things. All of the tests cover you on what's the most common adverse effect of therapy. All of the exams cover you on which of the following is the physical finding most likely to be found. But for this, on your step 2, complex 2, the thing that you need to know is the order in which to do things. So we're going to take this as an example, and we're going to be also following the order of the Master of the Boards book. You will not find this here as a word-for-word excerpt from the Master of the Boards book. It's simply that we'll follow it as a reference book and go in the order of the diseases, and that's it. This is basically a live class that has been filmed to follow the order of that book so that you know what it's like to go from beginning to end as if you had me in your classroom with you from beginning to end of medicine. Now, here we have a 68-year-old man or woman, and it doesn't matter because by the time a woman is 10 years postmenopausal, her coronaries act as if they were in fact male. And overall, more women die of coronary disease and heart disease than men do. They just do it at a slightly older age. 68-year-old man or woman comes to the emergency department with 30 minutes, 20 minutes of crushing substernal chest pain. Then what we know is that if the pain says that it changes with position, that's got a 95% negative predictive value that says this is not coronary disease. If it says it changes with respiration, it's pleuritic, it's a 95% negative predictive value, it's not coronary disease. If it says that there's chest wall tenderness, there's a 95% negative predictive value that it's not coronary disease. And there's an advantage to being on a board test, which is in life, anything could be anything. In life, you could have no chest pain and be having a myocardial infarction. In life, you could be having no chest pain, just have sudden death. You can rupture things. But on your test, if they want you to know the answer, they have to tell you something. If they want you to know the answer, they have to let you know. So if they want you to know it's not ischemic in nature, they'll tell you positional pleuritic or tender, and it will tell you it's not coronary disease. Next thing is, which physical exam finding is most specific for a myocardial infarction? There is no physical finding that tells you you're having a myocardial infarction. There's not even a physical finding that tells you you're having coronary disease. We know that you can have an S4 gallop as atrial systole into a stiff, non-compliant ventricle. You can have S4 gallop with left ventricular hypertrophy as atrial systole into a stiff, non-compliant ventricle. You can have an S3 gallop as signs that the ventricle is failing. These are bad prognostic findings, particularly this. TIMI scores and TIMI tells you you're going to die, but there is no physical finding. So if they want you to know the story, they have to tell you something. And look at this here. How do you know what test will become abnormal first? What is the best initial test? Well, this is all chest pains are always with an EKG first. But the EKG can't tell you for sure you're having an infarction. We know that ST segment elevation is associated with an infarction 75% of the time, but 25% of the time it's not an infarction. We know that ST segment depression tells you that 75% of the time you're not having an infarction and 25% of the time you are. So even these are suggestive. Ultimately, until you have enzymes, you can't tell. So which test, which enzymatic test, which enzyme test will be positive first? What becomes abnormal first? What's abnormal first is myoglobin. Myoglobin can become positive in as early as 1 hour after the onset of pain. And you might say, well, how come we don't use myoglobins? I never saw my attendings use myoglobins. How come I never saw that myoglobin being used? Well, you could. Personally, if I knew that I had a myoglobin negative at 4 hours, I don't care if it's not specific. It's like, wow, my myoglobin is negative at 4 hours. I don't have an infarction. I'm happy. So it's sensitive, but not specific. It peaks out at about 4 hours. It'll peak at about 4 hours, whereas CKMBs and troponin, CKMB and troponin don't even begin to go up for 3 or 4 hours, and they peak at somewhere around 12 and 18 hours. So within the first hour like this, there is no way to be sure it's truly an infarction. There is no way to be sure. Reinfarction, it's 3 days later, 4 days later, and I want to be sure that there's no reinfarction. You're having a new episode of chest pain. Are you repeating your infarction? You're having another one? What test do you use? EKG and CKMB. How do I tell whether somebody's having a reinfarction? The CKMB, because troponin stays up for 1 to 2 weeks, and CKMB will come down in 1 or 2 days. CKMB will come down in 1 or 2 days. So therefore, reinfarction 3 days later, 4 days later, CKMB. So it means if I have no physical finding that could tell me I have an infarction, if I have no enzyme in the first hour, maybe not even for 3 hours, not even the non-specific myoglobin, LDH is always wrong. If I have no blood test that can tell me it's an infarction in the first hour, and I have no unique physical findings, and risk factors like hypertension, the most common risk. Diabetes is the worst risk. Hypertension is the most common risk. Diabetes is the worst risk. Tobacco smoking gets better. Lipids, and family history. And you got a problem and you don't know who to blame it on. That's what we have families for, family history. Well, they're only risks. They don't tell you for sure you're having a myocardial infarction. There's questions that go with them. Yeah, what's the most common risk? Hypertension, the worst risk, diabetes. Which of them improves the fastest after fixing it? Tobacco smoking, stopping tobacco. So ultimately, all you have to make a diagnosis is a history and an EKG. No physical findings, no unique physical findings, and in the first hour, no blood tests. So a history and an EKG. Now, whether it's ST segment elevation or ST segment depression, the best initial therapy doesn't change. You see, why learn it twice? Here, what would you want you to know for your test about this subject? It's the most common cause of death in the United States. Pretty important, right? So what would you want you to know? Well, the things I just said. No physical findings, no blood tests in the first hour, history, and the EKG. The thing you'd want you to know most is, do you know which things actually lower mortality in the treatments? Or are you going to waste everybody's time and lives by giving oxygen first so you can get a nice acronym like MONA, so you have an O in the MONA? Oxygen doesn't lower mortality. Matter of fact, doesn't do anything unless you're hypoxic. Morphine and nitrates are good. I like morphine and nitrates. Morphine and nitrates is very nice. But what lowers mortality and is used in both of them is aspirin. Chew, 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 low dose, chew, 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 aspirin. Whether it's ST elevation or ST depression, aspirin is the best initial therapy. What's the difference between the person with the low score and the high score? The person with the low score knows to get an EKG and give an aspirin. The person with the higher score is able to say this. A person comes in with crushing substernal chest pain, abnormal EKG, aspirin has been given. What is the next best step in the management of this patient? For all acute MIs, a second antiplatelet drug, clopidogrel. You can't go wrong with clopidogrel. The alternatives to clopidogrel, especially if you're going to be stented, the alternatives to clopidogrel are prasugrel and ticagrelor. Prasugrel and ticagrelor. What's the alternatives to that? Prasugrel, not in the elderly, not above 75, ticagrelor, P2Y12s, P2Y12 inhibitors, not all of them, aspirin and a second antiplatelet drug. Now, what's the most important thing to be doing in this patient? It's not the enzymes. Now is here where it diverges. It diverges because if it's ST segment elevation, what's the most important thing you can do for someone in acute ST segment elevation MI? The most important thing you can do, besides giving them an aspirin and a second platelet drug, for ST elevation MI, this procedure lowers mortality most here than in any other area, is angioplasty, percutaneous coronary intervention. Percutaneous coronary intervention. That's the proper term for angioplasty, because technically speaking, it might be an angioplasty with a balloon, it might be rotor-rootering it out, cutting it out, might be using a diamond rotator in there, an intervention and a stenting. Now, all stents need 2 platelet drugs for sure for 6 months or a year. Percutaneous coronary intervention. If they want you to say thrombolytics, they will put in the story nearest cath lab, nearest catheterization lab, more than 90 minutes away, more than an hour away, because you're supposed to have that balloon inflated within 90 minutes. Nearest cath lab will not allow them to be in the window of 90 minutes, because when you're supposed to get that intervention done, you're supposed to get it now. History, physical, EKG, 5 minutes. History, physical, EKG, 5 minutes. If you're going to use thrombolytics, you should have those thrombolytics in the door in that person within 30 minutes of coming in with chest pain. Within 30 minutes, door to needle, 30 minutes. This becomes confusing for people. Up to how many hours after the start of chest pain does thrombolytics lower mortality? Well, that's a different question. You see, if you're going to get thrombolytics, it should be given to you within 30 minutes of coming to the door. But up to how long after the onset of chest pain does it still benefit you? Oh, that is a different question. And the answer is 12 hours. 12 hours. See, if you use those thrombolytics within the first 1 or 2 hours, you have as much as a 50% reduction in mortality. On Aldridge, though, it's about 25% reduction in mortality with thrombolytics. But after 12 hours, there isn't any benefit. Thrombolytics within 12 hours of the onset of chest pain. 3 and 4.5 hours is with a stroke. 3 and 4.5 hours is with a stroke. 12 hours with chest pain. Which of these is superior? Angioplasty is superior. But only 20% of the hospitals in the country can do primary angioplasty. Only 20%. Here's where it diverges, because if it's ST segment depression, or it is T wave inversion, or it is anything except ST elevation, not ST elevation, then the therapy after aspirin, the second antiplatelet drug that benefits the most, the therapy that will benefit the non-ST segment elevation MI the most, you see a non-ST segment elevation MI is a clot that's in the process of forming. It's a clot that's in the process of forming in the coronary artery. Do thrombolytics stop clots from forming? Do thrombolytics stop clots from forming? No. Thrombolytics take a clot that's already happened inside the coronary artery and busts it open. But thrombolytics don't stop one that's forming. What anticoagulant do we give people to stop clots from forming? And that is heparin. Low molecular weight heparin. Enoxaparin. Bonus point, bonus point, bonus point. What if you have heparin-induced thrombocytopenia and you can't use it? Heparin-induced thrombocytopenia, then we use fondaparinux. Fondaparinux, it's a 10A inhibitor. Fondaparinux, it's a 10A inhibitor. Bivalirudin and loperidin and bivalirudin are hard to use. They cause more bleeding. But fondaparinux can be used with heparin-induced thrombocytopenia because heparin prevents clots from forming, but heparin does not dissolve clots. Heparin prevents clots from forming, but heparin does not dissolve clots. Heparin prevents clots from forming, but does not dissolve clots. That's the single greatest difference between these two types of coronary syndromes. Because let me tell you what's not different. Everybody gets metoprolol. For sure, lowers mortality. Everybody gets a statin because you don't know what the LDL is. And besides that, you have coronary disease. So everybody gets atorvastatin, rosuvastatin, atorvastatin, rosuvastatin, atorvastatin, rosuvastatin. Everybody should get an ACE inhibitor because you don't know who's going to have a low ejection fraction till later on. So you give it to everybody until you know who's going to have the low ejection fraction later on. You don't know what the LDL is. That doesn't matter. Give them the statin. You don't know what the ejection fraction is going to be. Give them the ACE inhibitor. You don't know yet until you can observe them for a while. Everybody should be getting 2 antiplatelet drugs, a beta blocker, an ACE inhibitor, and a statin. We shouldn't even be having to remember this. What a stupid system to have a system of medical education and care that's based on human memory. How absurd is that? Oh, finally, where's our morphine and nitrates? I like morphine and nitrates. Morphine, nitrates, here you are. There's some nice morphine and nitrates. But the thing that you need to know most is angioplasty lowers mortality the most in ST segment elevation, myocardial infarctions. Thrombolytics is used if you can't get yourself to a catheterization laboratory. And remember, you have to have that balloon up in 90 minutes. If you are going to use thrombolytics, you got to use them within 12 hours of the onset of pain, 12 hours of the onset of pain. Oh, don't mix this up. Heparin, low molecular weight heparin, enoxaparin for a non-ST segment elevation. And metoprolol lowers mortality, statins lower mortality, ACE inhibitors lower mortality if there's a low ejection fraction. Oxygen makes you look like you're on a television show. That's good enough, I suppose. And then finally is, remember, thrombolytics is only if you're not bleeding or had recent surgery, then you can't give them. For instance, if your blood pressure is above 180 over 110, you can't be getting thrombolytics. If you had surgery in the last 2 weeks, if you're having melena sounds like a nice name, right? That's black stool. Can't give thrombolytics. Intracranial lesions, can't give thrombolytics. Hemorrhagic stroke ever, can't give thrombolytics. Non-hemorrhagic stroke in the last few months, 6 or 12 months. What about guaiac positive brown stool? Guaiac positive brown? Now I'm starting to sound like a wine aficionado, stool aficionado. C'est un nice bouquet de guaiac positive brown. Can you get thrombolytics if you have guaiac positive stool? Yes, you can. So why do you have to do those rectal exams if you can give it to people who have guaiac positive brown? I don't know, you don't have to. Don't walk into your test without knowing everything that's on this board. Don't walk into your test without knowing that angioplasty lowers mortality most with ST segment elevation myocardial infarction, acute MIs. We use it in 1 or 2 vessel disease, but a mortality benefit in stable angina has been hard to find, not compared to maximum medical therapy. We lower mortality with bypass if people have 3 vessel disease, 70% in each, 70% in each, 70% in each, or left main coronary disease, or 2 vessels in a diabetic. Now, you don't have to agree with the things that I say in this course or with my co-teachers. But we are the authors of the best-selling textbook that there is for Step 2 in the world. And we take very seriously that responsibility to make sure that you know what you're doing, both for patients and for test day. Now, I can't be everywhere that you are and take care of patients with you. But this is the closest thing that I can do, is to reach out to you through your mobile devices, through your smartphones and iPads and laptops, desktops, to try to be with you and prevent you from making mistakes that will either hurt you on your examination or hurt patients that you want to take care of. I believe that nearly every single person who passes through this process of learning medicine badly wants to do well and wants to take care of a suffering humanity. And we're here to help you do it. I also think that if you keep patients first and keep the love principle, that you have a love for humanity. Now, you don't, at the center of what you're doing when you're learning, it'll make all of your studying much easier. You see, the antidote for your fear of the examination is to remember the goodness of what you're learning. You cannot see your test as good and true and pure and noble and helpful and be frightened of it at the same time. Because it is about learning medicine that's going to help save sick people in their hour of need. And you'll be excellent at doing so. So my strongest suggestion for you is that you re-examine your commitment to wanting to be in medicine. If you find yourself frightened and nervous about the test only, then you're more worried about yourself than you are about the sick people that you are training to help. If you're more worried about the sick people that you're training to help, you realize you have to know everything. You have to know everything because they need you. And that will be the antidote for fear. The Sufis say that grace, as in grace of God, is like an invisible rain that comes down all the time. So I would say to you that the beauty and the goodness of what we're studying here in this course is like an invisible rain of love and goodness that comes down all the time. And if you lift up your hand and take some of it, your own fears will dissolve, you're going to do great on the test, and you're going to be able to protect people. See you soon.